Uh, a very warm welcome to everyone. On behalf of Meril Life Sciences, I, Shonal Shinde, welcome you to Taiwan Society Cardiac Interventions Autumn Meeting 2020. Uh, the symposium, our symposium will start soon. The earlier session of the TSCI meeting continued further, so there is a slight delay of 2 to 3 minutes. We will start this session in next 3 to 5 minutes. Thank you.
Welcome.
Hello, Shono. Hello. Hello.
Yes, Lisa, we can hear you.
Hello.
Yes.
Yeah.
Yeah, I can hear you. Yes.
Hello,
Yes,
it's
Lisa, we are
Dr.
live.
Philip speaking.
We are standby.可以吗？画面可以切出来了吗？Hello, Shono.
Yes, Lisa, we are good to go. We are waiting for you to initiate. We are waiting for you to start.
Okay, our meeting is going on now.
Okay.
Good evening, everybody. Now our evening meeting will be going on. So I will introduce our person here, come here to opening. Thank you.
Okay, our distinguished guest, Professor Santoso and Professor Alessandro Lupi and Professor Dobrin Vasilev. Can you hear me?
Yes.
Oh, yes, okay. I'm Dr. Xue Zhang.
Yes.
Yeah, at first, welcome to join this evening symposium of TSCI of the Autumn Scientific Meeting. So in this meeting, we will discuss about the biomimorph, this very special stent design. And actually, we also have some panelists over here. So I think this meeting will be very successful and will be very educative. And of course, we know we have three experts from different countries to join this meeting. And at first, because time is limited, at first, I would like to invite Professor Yin to moderate the first speaker and the Professor Santoso. Thank you very much. Thank you for your coming and for your join this meeting. Thank you very much. Thank you.
We will show our morph video introducing now.
Dear colleagues, it is my great pleasure to be here and chair the first speaker, my good friend and old friend, Dr. Sentoso. Dr. Sentoso is professor of medicine of the University of Indonesia Medical School and Medistra Hospital. He is a world-renowned expert and a master in the field of interventional cardiology. I personally don't have much experience regarding the use of this novel stent, but I think my best friend, he do have some, I mean, extensive experience on using this novel device. And I'm really happy to be here, introduce Dr. Sentoso to give us the first talk, the biomimorph. Dr. Sentoso, please.
Just a second. Just a second. I have a little bit of problem. But anyway, can you see my slides?
Yes.
Yes.
Show on the full screen. Yeah. Thank you very much.
Can you see my slides?
Yes, please go ahead.
Okay, first of all, Dr. Yin, it's nice to see you on the screen. Dr. Xie also. First of all, I would like to thank the organizing committee and also Meril for kindly inviting me and giving me the honor to speak in this very prestigious meeting in Taipei. My task is to describe a new type of stent. For us, it is I've been using this for many years, but this is a very unique, novel, uniquely designed tapered sirolimus eluting stent. This is probably first in the world. Sorry. So we know that long diffuse lesions is a special challenge for PCI. For the in the right coronary artery, long lesions are usually tubular and none or less tapering. In the right and the left system, long lesions usually give off side branches, and usually they taper as soon as side branch arises. And most branching coronary arteries taper in diameter by at least 0.5 millimeter over 20 millimeter of vessel length. So why do vessels taper? We know that in coronaries, tapering occurs as soon as the side branch arises. And the purpose is the purpose of the natures is to deliver blood efficiently to the side branches. And usually we know we follow the Finn's law, which is like this: diameter of the main vessels equals to 0.678 times the summations of diameter of main vessel and also diameter of the side branch. So if we know the diameter of these two limbs, the diameter of the third limb can be calculated. If the correlations between the diameter is disturbed, for example, if we implant a stent, then efficient blood supply cannot happen. So there are several issues associated with long diffuse lesion stenting. First, we can fix this by implanting overlapping stents. Second, we can also use long stents if the lesion can be covered by one single long stent. But for this, we need to do post-dilatations in the proximal part of the stent with larger balloon. So if we use DVS, for example, we can upsize the diameter to 0.5 millimeter. If we use the first generation of DES, we can upsize this to 1 millimeter only. If we use the latest generation of DES, particularly the platinum chromium stent, we can upsize this to more or less bigger size, 1.5 millimeter. But another option would be to use tapered stent. And I will deal with this a little more in detail later on. So there are several challenges if we fix the lesions with overlapping stents. First is hemodynamics, because we will have a low wall shear stress in the overlap zone, and this can be associated with later problem like, for example, neointimal proliferations and so on. And also polymer inflammations, because there will be twice the polymer dose, which may lead to polymer inflammation, especially in the overlap zone. Poor endothelializations at the overlap stents, and other problems like vessel rigidity, fractures, because that particular segment is more rigid, restenosis, and drug overdose. And other challenges are aneurysm formations, side branch jailing, over-radiations, the use of excessive contrast medium, and also cost, because multiple DS would cost more. If we use long stents, of course, we need to do post-dilatations in the proximal segment. If we use like this, for example, stenting to the proximal segment, we may induce dissection distally here. If we use stenting according to the distal segment, we may leave residual stenosis here in the proximal part. So tapered stent theoretically ensures better matching of the balloon stent and the vessel size. Imimorph is a uniquely designed sirolimus eluting tapered coronary stent system which identifies the unmet clinical needs. It provides anatomically correct treatment, first vessel conformability, because there will be no malleable struts or less of malleable struts. And second, homogeneous radial force can be ensured. We'll have better mechanical stress, and stent arterial wall ratio along the stented segment would be more ideal. And also we will avoid overlapping, and thus it may reduce fracture, blood flow, protuberances, shear stress, restenosis, stent thrombosis, and side branch jailing. And can very easily treat long and diffuse lesions with just using one single stent, one and done, and reduce procedural time, over radiation, contrast, and of course, the cost. So this stent is available in various sizes. Like for example, the smallest is 2.75 proximally and distally 2.25. And the biggest one is 4.5 distally and 4.0 proximally and 4.0 distally. And length varies from 30 to 60 mm. 60 is the longest in the world. The architecture is made of, the stent is made of cobalt chromium. It is one of the thinnest straps available, 65 microns. The design is a unique hybrid cell designs comprising an intelligent mix of open and closed cells, open in the middle portion and closed cells at the proximal and distal ends, and resulting in an excellent radial strength with high flexibility. Recoil and foreshortening is only 0.3% here, and recoil less than 3%. And it eliminates surface nickel oxide, so less problem of allergy. And the drug is sirolimus, and the polymer is biodegradable. And balloon is also short abrupt balloon, has a short abrupt balloon shoulders, and therefore it will minimize vascular injury. The stent has a very competitive radial strength combined with high flexibility and ultra-low strut thickness. As shown here in this bar diagram, this biomorph has a strut thickness of 65 microns, and it has a radial strength comparable to thicker stents like, for example, Fusion, Prokinetic, and Driver. Material is stronger than stainless steel, and this allows for thinner struts and while maintaining radial strength. And on fluoro, especially here, you see that the stent is denser, allows for identifications easy by fluoroscopy. And the stent is also more MRI compatible. Balloon construction is unique because a balloon overhang is very minimal. Short tapered shoulders will minimize balloon-related arterial injury as shown here. And the hybrid design will allow us for better side brand access or retention. So very ideal for side branch intervention. So this is again to show the summary of the unique features of the stent. This is the world's first and only tapered coronary DES available with closed cell design in the proximal and distal end here, and open cell design here in the middle part. The drug is sirolimus, polymer is biodegradable, stent is very flexible and deliverable. I will show you case examples. Minimal balloon overhang, and thereby minimal edge injury. It has optimal side branch access. This is just to showcase examples, several case examples. This patient has a long segmental calcified LED stenosis from proximal to distal segment. So of course, we need to do proper lesion preparations. And then after that, we introduce a 29 millimeter biomime. Look at the trackability of the stent, very easily track the vessels. And this is during stent deployment. And this is the very long tapered biomime morph stent, 60 mm. You see, trackability is excellent. And this is during stent deployment. And we achieve a very acceptable result like that. And this is another case example. Patients with line bifurcation stenosis here. Patient has also a lesion here, borderline severity. But the lesion at the bifurcation site and proximal LED as well as proximal LCX needs to be addressed. And this is on angio. Again, after lesion preparation, we introduce biomime here. It tracks very easily. We use the TK crush technique to fix the left main bifurcation stenosis. And this is the first case. And then this is a long tapered biomime morph, very easily introduced. Superb trackability is can be easily appreciated. And this is during deployment. Easy and fast deployment. And then, of course, we need to do the second kissing balloon dilatation followed by pop. And then we think that we felt that we need to fix the lesion, the mid LED. So we introduced another biomime across the other stent, which was previously implanted from the left main to the proximal LED. No, you can easily appreciate the superb trackability of the stent across the previously implanted stent in the proximal left main and LED. And this is the final result. Excellent. And this is my last case example. A very nasty looking lesion here, left main bifurcation stenosis with heavily calcified CTO in LED and LCX, and also very acute takeoff of the LCX angle. Angle is very challenging. And of course, after fixing the CTO in both vessels, side branches, and we implanted biomime. This is a long biomime, 48, very trackable here in the mid LED, mid and distal LED. So, and then another 2 overlapping biomime here to fix the lesions, the LCX and obtuse marginal. And then this is a long tapered biomime morph, 40 mm, easily navigated through the left main to the LED. And this is implantations of the stent from left main to the LED. And this is kissing balloon dilatation, decay crush. This is pot, and with implantations of another short biomime to cover the left main shaft and ostium. And this is the final result. I think very much acceptable. So in conclusion, I think it's a biomime morph provide anatomical correct treatment. This is the only tapered stent for tapered vessels such as LED or LCX. For long lesions in the RCA, of course, we can use biomime morph, but we can also use regular stent, regular and long stent, which is also produced by Meril. And a single long stent can cover lesions up to 56 millimeter. So we can use 60 mm biomime morph, longest stent. It provides a better vessel wall coverage due to uniform stent design. Provides optimal metal to artery ratio and thereby minimize restenosis and less aneurysm. The stent has excellent flexibility without any risk of fractures. No geographical miss because precision in the in-stent dimensions, and it provides procedural convenience of using a single stent only, one and done. And thank you for your attention.
Thank you. Thank you for your excellent talk, informative information, and excellent cases.
Thank you.
Amazing. Any question or comment? We can allow one. If not, can I ask, RCA seems to behave differently from LAD because it don't have much branches and works something like a conduit from segment 1 to segment 3. Do you think morph is still applicable in RCA, and will you use just one size balloon to dilate, post-dilate from proximal to distal?
What is interesting with right, even though it doesn't have a lot of side branches, but quite often the right coronary artery is tortuous, and this stent is very trackable. So to negotiate tortuosity, especially for example, if we are dealing with a very long CTO, quite often the CTO extends from the proximal to very all the way to the distal, close to the bifurcation. Sometimes we have patients like that. We can use this biomime morph very easily. It's very trackable, even though the lesion is very tortuous and very calcified. Of course, we need to address the calcifications. We need to do proper lesion preparations with ROTA or OAS or whatever. But after that, we can implant this very long biomime morph. We can save costs and save time and save contrast and so on, as I mentioned in my presentation.
There has been no much tapering, I mean the RCA. So do you still use the same size balloon to post-dilate the vessel from proximal to distal without tapering, I mean? Because the drug the stent was designed.
Stent balloon or different balloon? We can use the same the stent balloon or different balloon, but it also depends on the IFUS or OCT findings. If we need to optimize the result, depending on the result, the imaging information that we derive from the imaging devices, of course, we can use different balloon. But usually with just using the same stent balloon, balloon stent with the stent balloon, we can achieve good result.
Okay, thank you very much. Thank you for your excellent talk. I would like to switch my moderator position to Dr. Guo Fengyu. Thank you very much. Thank you.
Dr. Yin.
So the next speaker is Professor Alessandro Lupi. Can you hear me? Hi, Professor.
Yes.
I cannot hear you. Okay. So now I will introduce you to give us a talk. I know that you are an expert in cardiology and also a director of the Urbano Cusino Ostello General Hospital in Italy, and being the national President of Italian Council of Cardiology Practice on behalf of a European Society. And now you are the visiting professor of School of Medicine in Italy, and you also join many studies of the international randomized control trial and have many manuscripts. So would you please tell us your experience with a long taper biomime stent in Italy? Professor, please.
Thank you. I share the presentation. Can you see my screen?
Yes, we can see.
Okay, I start. First of all, I want to thank Meril for inviting me to this prestigious meeting at your association, the Taiwan Association of Interventional Cardiologists. My task is to talk about our experience, our personal experience with the long tapered biomime amorphous sirolimus eluting stents. In our daily practice, we have to tackle complex situations, and the choice of the appropriate device is critical. We have now, after a lot of years of study, a clear idea of the identikit of the perfect stent. We need a stent with a thin struts covered with a bioresorbable polymer and releasing sirolimus. If we compare a second generation stents with the previous one, as we did in a previous our publication in CCI in 2014, we can easily observe that stents with the thin struts, bioresorbable polymer, and loaded with sirolimus showed the best performance, the best clinical performance, both in terms of late lumen loss, late stent thrombosis, and late lesion revascularization. And biomime is really a mature second generation drug-eluting stent. with a really thin stent struts, bioabsorbable polymer loaded with sirolimus, and represents an ideal choice as a workhorse device for the real-life duty of a typical cath lab. With these premises, the results of the MERIT 5 trials were largely predictable, with a better clinical performance of BioMime over science, at the time the standard for clinical research comparisons, both in terms of MACE and recurrent MIs. Moreover, BioMime struts design makes this stent really refractory to problems like foreshortening and longitudinal stent deformation, which affected very popular devices like Promus Elements, Everolimus eluting stents, and the lower stent, Resolute Integrity Zotarolimus eluting stent. But why do we need a long tapered stent? In the previous presentation, there was an excellent depicting of the reasons why we need a long tapered stent. In our daily practice, we face important clinical problems that might deserve dedicated device. And one of them is the treatment of very long coronary artery stenosis. It is a common problem, accounting for about 10% of all the lesions that we face in our daily practice. And we have important advantages deriving from using long tapered DES. In the previous presentation, they were excellently described. So I save time and I go further. BioMime Morph maintains all the smart characteristics of BioMime, but is specifically engineered for fixing very long coronary lesions with a tapered design to respect anatomy, but also with a small profile and excellent flexibility to allow deliverability in such difficult situations. Obviously, long coronary stenosis, particularly in the presence of calcium and tortuosity, represent a challenge. If you want to benefit from the deployment of a favorable clinical, of a stent with a favorable clinical characteristics like BioMime, in particular, in this case, BioMime Morph, we need some tips and tricks to deliver it. First of all, we have to carefully plan our procedures. So we need to know exactly what we are going to treat. Thus, the employ of imaging like IVUS and OCT is strongly recommended. Second, we have to be familiar with the high support wires, body wires techniques, child in mother, like guideliner, GetZill, and so on, and anchoring techniques to improve stent deliverability to the target lesion in difficult situations. Optimal vessel preparation is mandatory. Thus, we have to use non-compliant balloons with high pressure, cutting balloons, scoring balloons, rotablation, when available, orbital atherectomy, and shockwave to modify the calcium of these difficult plaques. Fourth, we have to remember when approaching a bifurcation that cells in Morph in the proximal and distal part of the stents are closed. So we have to stay away from bifurcation in this part of the stent. And we have to anticipate the space for proximal optimization technique. So we need a longer stent because we have to take account for the space for doing pot. And finally, even after a meticulous planning and preparation, we have to anticipate a small percentage of failure to deploy the stent. This has, however, no deleterious effect of the procedure success or complication rates in our experience, because if it's at the end impossible to pass the stent, to deploy the stent, you can safely revert to a two-stent strategy, overlapping stent strategy, and perform the intervention without complication. This is our experience with Morph that we recently published in Cardiology Research in this paper. And our experience started in 2017 when the stent was available for the first time in Italy. And in about 1 year, we enrolled 272 patients in a prospective registry. These are the clinical characteristics of the patients the first year of our activity. 25% of diabetic patients, 14% of patients with chronic renal failure, and 8.5% of patients with the CTO. The use of even very long stents did not create problems with the use of the radial access, as you can see. And the device success was extremely high, 96.3% in the overall population, and 98.3% in the population of patients that received the longer stent, the 60 millimeter stent. Of note, about 20% of patients needed an approach with the body wire technique. And this approach, this figure rose to 30% in patients receiving the longer stent. If we perform the multivariate analysis, we can find the independent predictors of Morph failure. And the independent predictors were the stenosis length and the severe tortuosity, while the presence of severe calcium was not an independent predictor of failure of stent deployment. However, in each case of stent deployment failure, there was the possibility to use a simpler technique of overlapping stent without any complication. So we had our procedures with the BioMine Morph were completely safe. To give an idea of what can be the use in a daily life practice in a normal cath lab, I want to share with you this case of a minimalistic CTO treatment with a single BioMine Morph that's deployed. A male patient, 77-year-old, hypertensive, dyslipidemic, with the normal baseline ECG. The patient suffered from moderate work load effort angina since 1 year, and recently his symptoms had worsened. He had a stress ECG test positive for angina and diagnostic as depression. And at the echocardiography, we had a preserved global left ventricular ejection fraction with an apical hypokinesia. This is the diagnostic angiogram. As you can see, we have a CTO of the medium distal LAD with a JCTO score of 2. There is also a stenosis, a long stenosis of the obtuse marginal branch. and no collaterals. I have not the figure, but no collaterals from the right coronary artery. This is the tentative of crossing the CTO. We place the BMW in a septal branch to mark the vessel, and then we attempted to pass the CTO through a cyan blue guide wire, but the tentative was unsuccessful. Then we used another guide wire, a cyan regular guide wire, and this was successful to pass the CTO. Then we exchanged this guide wire to avoid problems of perforation and to have a more supportive guide wire through a microcatheter with a BHV guide wire. And this is the stent deployment. It was very easy to pass after predilation of the lesion. A long biomimorph stent, 3.0, 2.5, 60 millimeters biomimorph deployed at 16 atmospheres. And this is the result, the nice result after final dilatation at high atmospheres, at high pressure with non-compliant balloons. You can see that all the LAD, the diseased segment of the LAD is perfectly covered with the stent without a residual stenosis. So we only decided to spare the ostial lesion because at IVUS evaluation, it was the minimal lumen area was quite big. So we performed this intervention using 4 guide wires, 1 IVUS probe, 1 biomimorph, and 3 non-compliant balloons. So a very cheap intervention for a quite difficult CTO. So, concluding, I hope that this presentation will be a stimulus for trying a device that could really assure for the interventional cardiologist the use of a very good stent that has important clinical results, and also give the strength of a good intervention with great safety and the possibility of use a simple material that is affordable for almost every cath lab in the developed countries. Thank you.
Thanks, Professor Alessandro's talk. Is any question from the audience or the panelists? We can, due to only allow 1 question due to time issue. Is there any question? Okay. Then, Professor, I will raise 1 question regarding the very long length of the stent. In your case, the circumference was very tortuous and angulated. You just put a 2.5 by 60 stent in LAD. But how about the circumference? If it's also diseased in such angulated circumference, where you also use such a long stent to treat the circumference? If you meet the vessel with angulated and maybe the stent not easy to pass, will you still use the 60 millimeter stent?
In our experience, it is not impossible to treat such a lesion with a single long stent of 60 millimeters. But as you see in our multivariate analysis, angulation, tortuosity is really an important issue to to anticipate the failure of the stent. So if the angulation is extreme and the stent that you have to pass to deploy is very long, I think that that could be case in which planning could avoid a stent like this and try other strategies. I think that especially the LAD is ideal for the placing of this stent because we have a quite direct passage. We have a very limited tortuosity, and the success in this case is we can anticipate almost complete success to use. So the chance to spoil a stent is very less probable. If you want to reason about great numbers and you have to spare on the economical point of view, you have to choose the right stent for the patient also without with the low rates of failure of using material. I think that in that case it's better to find other solutions.
Yes, we totally agree with you. And due to time issue, we are going to leave you. And thanks, professors, excellent talk, and thank you. Now I've moved the next section and hands my chair to Professor Xu. Professor.
It's my great honor to be invited here. And let me introduce the next speaker, Professor Vasilev. Dr. Vasilev, our professor, has published numerical articles and joined many international randomized control trial and contribute a lot in this interventional cardiologist. He's now the head cardiology clinic at Alessandro University Hospital in Bulgaria. Professor Vasilev, please share your by-my-morph cases with us. Thank you. Please go ahead.
So, dear chairs, dear organizers, I would like to thank you for invitation to make my presentation. Also, I would like to thank to Meril for inviting me to share my experience with by-my-morph. The previous speakers talked in detail about the advantages and the new science of by-my-morph. We started working with the device from 2017, and it appeared very useful and very advantageous device for our patients. The tapering of stent is unique and is the only one in the world at that moment. And the stent has a hybrid design with the closed cell at the ends and the open cell at the larger part of the stent. So it gives an opportunity to treat quite a different and complex type of lesions. By-my-morph provides anatomically corrected treatment with its tapering and coverage exactly the vessel anatomy. With one single stent, we can cover a lesion length of more than 5 centimeters, which is quite important. One additional advantage, at least in our country, is because we have reimbursement limitations for up to 4 stents per year per patient. And with that stent, it allows us to treat more complex lesions in one sessions. placing one long stent instead of two or three another stents. And another advantage, at least for me, is very good uniform stent design and lesion coverage, which gives very good expansion of the stent and very good long-term result, as I will show you after a few minutes. So the optimal metal to artery ratio, because of the thin struts, is predisposing to low restenosis rate. There is no geographical miss, and stent precisely covers the all long lesions. And the stent is quite useful, at least in our hands, because we can insert it in very tortuous calcific lesions. It is very flexible, so it's a very, very useful device. For the period of time of 2014 to December 2019, we implanted biomime in 272 patients, 255 patients, and from 2017 we started with the biomime morph, implanting 50 stents in 49 patients. You can see the distribution of lesion types where we used biomime and the biomime morph. As you can see, more than half of our morph implantations were in CTO lesions and in bifurcation lesions. Practically in left main CTO and bifurcation encompass 90% of all morph implantations. So in general, morph was implanted in very, very complex patients. The results at 2.5 year follow-up are quite good. These are results for morph patients with TVR rate of only 6% for 2.5 year. We follow very strictly our patients, so this is the real restenosis rate, which I think that in this very extremely highly complex patient population is quite good. I'll present two cases from our patient population just to demonstrate how we use biomime morph. The first one is 76-year-old female patient with unstable angina with the risk factors of arterial hypertension, diabetes, and dyslipidemia. The patient had previously implanted one biomime morph 30-25 to 60 for the CTO in the LAD, and now she admitted for the second session of the CTO of the right coronary artery. There is a relatively good ejection fraction of 52% and apical and inferior hypokinesia. This is the anatomy of the patient. You can see that there is a moderate stenosis on the left main, which was previously assessed, and at this time it not requires any treatment. And the previously implanted morph in the LAD is well visible in the LAD. The right was collaterally filled from the LAD, and there was a blunt stump at the beginning of the right. So we proceeded with the antegrade approach, and it was possible to cross the lesion with the Gaia first and XTR. On the Corsair Pro, then the lesion was dilated with multiple balloon inflations, and we implanted at the distal part of the lesion one regular biomime 25 to 32 and one long biomime morph at the proximal part of the lesion. So this is the result after the implantation of the two stents. So we have to finish our work by opening the posterior descending and the most distal posterolateral branches, which was achieved, and this is the final result of this case with the recanalization of the right coronary artery, as I said, with two biomime and biomime morph stents. The case 2 is a 69-year-old female with, again, with unstable angina and arterial hypertension, with no previous history of coronary artery disease, but with a moderate decreased ejection fraction and inferior basal hypokinesia. And the patient had three vessel disease with the diffuse lesion in the proximal LAD and severe lesion at the first diagonal, also the severe lesion at the proximal circumflex and the first marginal branch, and subtotal occlusion of the right coronary artery with quite good antegrade filling of the right coronary. So we decided to accomplish the complete revascularization of this patient, and after crossing the lesion of the right coronary, one biomime morph 35 to 3 to 60 millimeters was implanted in the right, and we revascularized the right coronary. Then we switched to the left, and after predilatation of the LED with 25 to 20 balloon, one biomime 25 to 29 was implanted in the mid-distal LAD. Then biomime morph 35 to 3 to 50 with the potting in the left main with the 4.5 balloon was done, and this is the result after stenting the left main and LED. So we opened the diagonal with the balloon, then the circumflex was crossed with two wires and predilated. Additional biomime was implanted, and this is the final result for this case, which is quite acceptable for the patient. And this is another view. So in conclusion, the biomime morph is an excellent choice for complex and long coronary lesions. It's a good option just to have a very good lesion preparation with the ballooning, carota, scoring balloon, or now with shockwave balloons, which we have. The design of the stent is readily appropriate for treatment of all types of bifurcations, including the left main. The midterm results, at least in our practice, are good, taking into account the very complex nature of the patients when we treated with the device. Thank you.
Thank you. Thank you. Thank you, Professor Vasilev. We appreciate your contribution to this scientific program. And sorry for the because of the time limit and the schedule is leaving behind, we have to leave you here. And thank you again. And I will invite President Shet for the closing.
因为时间的关系哈，我就简单的 closing 一下关于这个新的 BioMide 的 MORPH 这个 stent， 基本上它是一个 long stent， 然后 taper stent 哈，所以对于像例如 LED 这种比较长而且 taper 的一个 lesion， 它应该有它独特的一个角色，而且看起来第一个它比较符合 anatomy 的一个 morphology， 第二个就是它不需要用到，因为很长不需要用到 overlapping 的 stent， 那第三个它也不需要太过度的 over dilatation， 那第四个就是 cost saving 啊，那而且看起来它的 radial force 还有 shortening 的 percentage 都小于 3%， 非常的少。那它也用到了 resorbable polymer 跟那个有效的 sirolimus 的一个药物，所以基本上我想以后大家有机会的话，应该会有越多的一个经验，会 accumulate 起来，那到时候大家可以再做进一步的一个 sharing 哈。那最后谢谢长透公司帮我们安排这么好的 evening symposium 哈，那对这个新的 stent 有更进一步的一个了解哈，谢谢大家的参加，谢谢各位，谢谢。那另外就是隔壁等下会有临时会员大会，再麻烦大家有空可以参加一下，谢谢。小赖，谢谢。